In this section, we will talk about presenting complaints one by one, starting from this chapter, which will be about the patient with thoughts of suicide or self-harm. Then we will talk about the patient with impairment of consciousness, memory, or cognition. Then with alcohol or substance use problems. Then to talk about the patient with psychotic symptoms. Then the patient with elated or irritable mood. Then the patient with low mood. Then the patient with anxiety, fear, or avoidance. After that, we will talk about the patient with obsessions and compulsions. Then to talk about the patient with a reaction to a stressful event. Then to talk about the patient with medically unexplained physical symptoms. And after that, we will talk about the patient with eating or weight problems. Then we will talk about the patient with personality problems, and to end with the patient with neurodevelopmental symptoms, inshallah. So let's start with this chapter, chapter 6. The patient with thoughts of suicide or self-harm. And you can notice that the importance of this chapter, that's why we start with it. We have this case that we will discuss later on, but let's just look at it. The duty psychiatrist is asked for their opinion on Mr. S.A., a 28-year-old unemployed, recently divorced man who was brought in by his landlord. The landlord had called round to discuss payment arrears, only to find the door unlocked and Mr. S.A. asleep on his bed with an empty box of paracetamol tablets and several empty cans of larger littered around the floor. He also found a hastily scribbled suicide note on the bedside table, addressed to Mr. S.A.'s children. Mr. S.A. was easily roused but was upset to have been found and initially refused the landlord's pleas that they go to the hospital. So, was easily roused but was upset to have been found and initially refuses the landlord's pleas that they go to the hospital. Only when he was violently sick did Mr. S.A. finally agree. The doctor in the accident and emergency department reports that other than the smell of alcohol on his breath, Mr. S.A.'s medical examination was normal. Blood tests revealed raised paracetamol levels, but these were not sufficiently high to require medical treatment. The accident and emergency doctor is concerned because Mr. S.A. is ambivalent about further acts of self-harm or suicide, saying that his life is a failure and that there is nothing worth living for. Before coming to see the patient, the duty psychiatrist checks Mr. S.A.'s past medical and psychiatric history. We will discuss that inshallah at the end of this chapter. Let's talk about suicidality. While many psychiatric illnesses can be associated with self-harm or suicidal intent, both as a presenting feature and a chronic symptom, many patients who self-harm or attempt suicide are not previously known to mental health services. Assessments of these patients are often made by non-psychiatric staff. So, it is vital that all doctors are able to detect and manage any underlying mental illness and have a sound approach to assessing and managing risk. Let's talk about some definitions and clinical features. What is self-harm? Self-harm is a blanket term used to describe any intentional act done with the knowledge that it is potentially harmful. It can take the form of self-poisoning, like overdosing, or self-injury, like cutting, burning, or hitting. Motives for self-harm are vast and include emotional relief, self-punishment, attention-seeking, and can even be a form of self-help actually, albeit maladaptive, by way of challenging an intolerable emotional experience into discrete physical sensation. So these are some, motives for that. Okay. Suicide is the act of intentionally and successfully ending one's own life. This is suicide. While attempted suicide refers to an unsuccessful suicide bid. Hints and tips. Self-harm is one of the top 5 reasons for acute medical admissions for both men and women in the UK. Further, it is estimated that a large number of people do not attend hospital following self-harm. So, what about assessment of patients who have inflicted harm upon themselves? So, here we are talking about assessment. Compared with the general population, which has an annual suicide rate of 0.01%, patients who present with self-harm have a 50 to 100-fold greater chance of completing suicide in the following year, resulting in about 1% of people dying by suicide. Emphasizing the need for comprehensive risk assessment, it is incredibly difficult to predict suicide reliably. But numerous studies have shown that certain epidemiological and clinical variables are more prevalent among those who have completed suicide. Here we have this box that to talk about this. And it is important to bear these in mind when assessing risk. So here we have this risk factors for suicide in this box. We have some epidemiological factors, clinical factors. About epidemiological factors, male of any age, this is a risk factor. Male of any age, younger females more likely to self-harm but less likely to complete suicide. Being lesbian, gay, bisexual or transgender, particularly younger people. Prisoners, especially remand. Being unmarried, single, widow, divorced, or this is being unmarried, either single, widow or divorced. Unemployment. Working in certain occupations like farmer, vet, nurse, doctor. These are some occupational, factors. Low socioeconomic status makes you more vulnerable to and prone to suicide. Living alone and social isolation. What about clinical factors? Clinical risk factors, of course. We have psychiatric illnesses or personality disorders. We will talk about them. Previous self-harm, alcohol dependence, physical illness, especially debilitating or chronically painful or terminal conditions, family history of depression, alcohol dependence, or suicide, recent adverse life events, especially bereavement. So all of these are risk factors that you should put in mind while, assessing risk. Let's get back to the text. No patient questionnaire or suicide risk scoring system has been shown to be better than thorough clinical assessment. The key areas to assess are 1. Suicide risk factors, we've talked about them. Suicide intent, including circumstances surrounding the act, we will talk about that. And mental state examination with current social support. So, there is no scoring system, there is no scale to do this. You should do thorough clinical assessment about it. Suicidal risk factors, suicidal intent, mental state examination, and current social support. Here we have a red flag. Suicidal thoughts and actions are common. In the general population within the last year, around 1 in 20% will have had suicidal thoughts. Around 1 in 200 will have attempted to kill themselves, and around 1 in 10,000 will have died by suicide. Suicide is the commonest cause of death in men and women under the age of 35 years, and the third commonest cause of years of life lost worldwide. And a lot of these studies is about, the UK and the Western countries in general, but except for those that are noted that, for example, these about worldwide things. Okay. Communication tip. Suicidal patients often feel distressed and guilty. One of the most important therapeutic aspects of the assessment is to convey empathy and optimism. Let's talk further about suicide risk factors. In the previous books, we've talked about suicidal risk factors, the epidemiological and the clinical risk factors. Let's talk about some of them. Psychiatric illness. About 90% of patients who commit suicide have a diagnosed or retrospectively diagnosable mental disorder. However, only around a quarter of these patients have contact with mental health services in the year before completing suicide. Patients recently released from inpatient psychiatric care are at a significant elevated risk for suicide, particularly during the first couple of weeks after discharge. Here we have a table that summarizes the most important psychiatric conditions associated with suicide. So these are the association between psychiatric disorders and suicide. First, we have the psychiatric disorder, then the risk relative to general population, and comments about that. So, personality disorders approximately have 40-fold suicide risk in relation to general population. Highest in borderline personality disorder, also strong association with antisocial and narcissistic personality disorders, and often have comorbid depression or substance misuse. Unipolar depression has 20-fold suicide risk greatest in patients with anxiety, agitation, or severe insomnia, and higher in patients having received inpatient treatment in the past. Risk greatest in first 3 months of diagnosis. Substance use. In cocaine dependence, it is 17-fold. In alcohol dependence, 12-fold. In opioid dependence, 7-fold. Amphetamine dependence, 5-fold. So the highest risk when comorbid with depression, of course. Schizophrenia has 13-fold risk relative to general population. The highest risk is young, intelligent, unemployed males with good insight and recurrent illnesses. Again, young males unemployed with good insight and intelligence, and of course with recurrent illness. Eating disorders. Anorexia nervosa has 8-fold bulimia lower risk than anorexia, but there is risk. Mortality in anorexia nervosa is also increased due to complications of malnutrition, other than the suicidal act. Bipolar affective disorder has 6-fold relative risk in relation to general population, more common in depressive phase, but can also happen in manic or mixed affective episodes. Anxiety disorders has 3-fold increased risk in generalized anxiety disorder, panic disorder, and post-traumatic stress disorder, even without comorbid depression. OCD not associated with increased risk, actually. Anyways. Communication tip. Every patient with suicidal ideas should be asked about alcohol or substance misuse, no matter how unlikely it seems. Taking a non-judgmental stance is likely to enhance the therapeutic relationship and help the patient feel understood. Physical illness. Many disabling or unpleasant medical conditions can be associated with self-harm and suicide. Often, a patient may have comorbid depression that will respond to treatment. However, a minority of patients have no mental illness and make a capacious decision to die. The most common examples are chronic illnesses which cause a lot of functional impairment or pain. Chronic obstructive pulmonary disease, asthma, stroke, epilepsy, and of course life-limiting illnesses like cancer, Huntington's disease. Recent adverse life events are also a common risk factor. Stressful life events are more common in the 6 months prior to a suicide attempt and include relationship breakups, health problems, legal and financial difficulties, or problems at home or within the family. So we've talked about suicide risk factors. Let's talk about suicidal intent. Suicidal intent, which is commonly defined as the seriousness or intensity of the wish of a patient to terminate their life, is suggested by the following. The attempt was planned in advance. A lethal suicide attempt typically involves days or weeks of planning. It is rarely an impulse, spur-of-the-moment idea. The exception is the psychotic patient who impulsively respond to hallucinations or delusions. So, planning is strongly suggested by the evidence of final acts. These include the writing of a will or suicide notes. Another factor about suicidal intent is precautions were taken to avoid discovery or rescue. For example, a patient might check into a hotel room in a distant town or ensure that no friends or family will be visiting over the ensuing hours or days. A dangerous method was used. Violent methods like hanging, jumping from heights, firearm use are suggestive of lethal intent. That said, use of an apparently ineffective method like taking 6 paracetamol tablets might reflect lack of knowledge of the lethal dose. The lethal dose needed rather than a lack of intent to die. Therefore, it should be ascertained whether the method used was seen as dangerous from the patient's perspective. Another factor about suicidal intent is this: no help was sought after the act. Patients who immediately regret their action and seek help are less at risk than those who do not seek help and wait to die. The person communicate with is often of significance. They may be someone whose behavior the patient is seeking to influence by their act of self-harm, and or they may be someone who provides support to the patient. So this was about, suicidal intent. So we've talked about suicidal intent and suicide risk factors. Let's talk about another thing that is important in risk assessment, which is mental state examination. This should ideally be conducted in a calm, quiet, and confidential setting, preferably when the patient has had a chance to rest and is not under the influence of drugs or alcohol. Check specifically for current mood state. Does the patient appear to be suffering from a depressive illness? Assess for features of hopelessness, worthlessness, or agitation, all of which are associated with a higher risk for completed suicide. Other psychiatric illnesses. Does the patient appear to be preoccupied, delusional, or responding to hallucinations? Is there evidence of eating disorder, substance abuse, or cognitive impairment? You check for that. Current suicidality. Current suicidality is the act narrow regretted, or is it's about the current suicidality. Is the act narrow regretted, or is there strong intent to die? What does the patient plan to do if discharged? Another thing to check: protective factors. What aspects of the patient's life, family, children, and dependents, would guard against further acts? Lack of protective factors or dismissal of their importance is a worrying sign. The following questions might be helpful when asking about suicidal ideation. Have you been feeling that life isn't worth living? Do you sometimes feel like you would like to end it all? Have you given some thought as to how you might do it? How close are you to going through with your plans? Is there anything that might stop you from attempting suicide? Hints and tips. Patients who are tired, emotionally upset, or intoxicated may appear to be at greater risk for imminent self-harm. Allowing some time to sober up and reflect can be of great therapeutic value. However, this will always be a matter of clinical judgment. So, how we manage patients after self-harm. So, patient management following self-harm or attempted suicide. Management planning should follow assessment of risk factors and mental state. It is important to remember that self-harm and suicidality are not discrete illnesses. Instead, they are symptoms reflecting a complex interplay of mental disorders, personality types, and social circumstances. Rather than taking the form of a prescribed care pathway, management of the suicidal or self-harm patient requires clinical judgment, taking into account considerations the needs of the individual patient and the availability of local resources. So again, rather than taking the form of a prescribed care pathway, management of suicidal and or self-harm patients require clinical judgment. So taking into account considerations, the needs of the individual patient and the availability of local resources. This can often be anxiety-provoking for healthcare workers. It is actually so. Formulation of a management plan should be made after a thorough review of any available past history, including care programs or crisis plans if relevant. It is always desirable to obtain a collateral history from a family member or close friend. A good plan should include both short and long-term management strategies. About immediate management considerations, management considerations include the following. Is the patient in need of inpatient psychiatric care to ensure their safety? If so, can this be achieved on a voluntary basis, or is the use of mental health legislation required? Would the patient benefit from the input of home treatment, outreach, or crisis teams? Does the patient have existing social support that could be called upon? Reducing access to means of self-harm. Does the patient have a collection of tablets or rope remaining in their home they could dispose of? Should their prescription medication be dispensed weekly or more frequently? So, because not to have, the drugs to suicide by. Longer term management involves the modification of factors that could increase the risk for further acts of self-harm or suicidality, and may include treatment of psychiatric illness, medication, self-help, psychological therapies, community mental health teams, outpatient appointments, general practitioner follow-up accordingly. Avoidance of substance use, of course, highlighting associated with suicide to patient, encouraging patient to attend voluntary organizations and or addictions services. Optimizing social functioning, social work, citizens advice bureau, community groups and activities. Encouragement of family support, voluntary support group agencies, and so on. And also crisis planning, relaxation or distraction techniques, telephone counseling services, information on assessing emergency psychiatric services. Okay, so we've talked about management for self-harm or attempted suicidal patients in the short-term or immediate management and in long-term. Discussion of case study. You remember the case that we've talked about in the first at the beginning of this chapter. So let's talk about it. So I would actually repeat it to remind you of that. So we have the duty psychiatrist is asked for their opinion on Mr. S.A., a 28-year-old unemployed recently divorced man who was brought in by his landlord. The landlord had called round to discuss payment arrears, only to find the door unlocked and Mr. S.A. asleep on his bed with an empty box of paracetamol tablets and several empty cans of larger littered around the floor. He also found a hastily scribbled suicide note on the bedside table, addressed to Mr. S.A.'s children. Mr. S.A. was easily roused but was upset to have been found and initially refused the landlord's pleas that they go to the hospital. Only when he was violently sick did Mr. S.A. finally agree. The doctor in the accident and emergency department reports that other than the smell of alcohol on his breath, Mr. S.A.'s medical examination was normal. A blood test revealed raised paracetamol levels, but these were not sufficiently high to require medical treatment. The A&E doctor is concerned because Mr. S.A. is ambivalent about further act of self-harm or suicide, saying that his life is failure and that there is nothing worth living for. Before coming to see the patient, the duty psychiatrist checks Mr. S.A.'s past medical and psychiatric history. So let's go to the discussion of this case. So let's do self-harm assessment. Mr. S.A.'s epidemiological risk factors are that he is young man, this is first, recently divorced, this is a second risk, unemployed, this is third risk, and lives alone, and is socially isolated. So all of these are risk factors, these are epidemiological risk factors, we've talked about them. So Mr. S.A.'s epidemiological risk factors are that he is young man, recently divorced, unemployed, and lives alone in social isolation. Okay. His clinical risk factors are that he may have alcohol problems and has recently experienced adverse life events, divorce, and financial difficulties. The evidence of final act, suicide notes, and the failure of Mr. S.A. to seek help after the act suggest a strong suicide intent. Okay? So final notes, failure to seek help, all of these would suggest strong suicide intent. Here we are talking about suicidal intention, So the fact that he would not have been discovered but for the landlord's timely arrival indicates a degree of forward planning, although he is leaving the door unlocked, and his willingness to go to hospital after vomiting suggests some ambivalence. So he is willing to die because he was not happy that he was found, but also he's not locking the door, and at the end he accepts to go to the hospital. That would suggest some ambivalence. Mr. S.A. had consumed a significant quantity of alcohol at the time of the overdose, which could have clouded his judgment and increased his impulsivity. On mental state examination, Mr. S.A. has ongoing suicidal ideation and cognitive features of worthlessness and hopelessness, which are associated with suicide also. So, what should we do for this patient? Further management. The duty psychiatrist should ask about all the epidemiological and clinical risk factors, specifically about past or current mental illness. Is Mr. S.A. known to mental health services? Previous episodes of self-harm, alcohol or substance dependence, physical illness, family history of depression, alcohol dependence or suicide, and recent adverse life events. The duty psychiatrist will also be interested in Mr. S.A.'s current social support in order to try and help him formulate the most appropriate management plan. As this is a complex risk assessment, the duty psychiatrist will probably have to reassess the patient himself, especially as regards detecting mental illness on mental state examination. The psychiatrist might ask the A&E doctor to keep Mr. S.A. overnight, so that a mental state examination can be performed in the morning when he is refreshed and no longer under the influence of alcohol. A hospital admission or follow-up by a high-intensity support mental health team, crisis team, seems to be the most likely outcome. So, this is risk assessment, and further management for that. Let's have this summary. Chapter summary. Self-harm is a very common presentation with many different causes. Self-harm increases the risk for completed suicide, but the vast majority of people who self-harm will not die by suicide. Assess risk for suicide in all those who have self-harmed by identifying risk factors for suicide, epidemiological and clinical, degree of suicidal intent, evidence of mental disorder, use of alcohol or other substances, and social support and supportive factors. Management is very specific to the individual, but should include crisis planning for all. That's it. هذا والله تعالى أعلم، وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.